Hey everyone, so if you're listening to this VOPP, that means I am not at peer tutoring and I'm in fact doing my long case presentation. Wish me luck, guys. So I'll be talking about infections of the CNS today. If I start coughing during this presentation, very sorry, it's unintended, but also I possibly definitely have pneumonia. Let's get started. So when I say CNS infections, what do I mean? What do you mean by a CNS infection? There are a few. So the most obvious and the most concerning one is meningitis, so infection of the meninges. And then we can also have an encephalitis, which is also extremely dangerous. So that's an infection of the brain parenchyma. We have meningoencephalitis, and that's an infection of both. And then we have brain abscesses. So that's just a walled off infection. And you'll see that has quite a variable presentation and a different presentation to meningitis and encephalitis in particular. So that's easy to distinguish. So, as I said before, CNS infections are very dangerous, and you want to make sure that you don't miss it on your differential list. So whenever you have a patient that comes in with a fever and a headache, nuchal rigidity, so that's neck stiffness, photophobia, or a change in mental status, seizures, focal neurological deficits, and in the case of an abscess, a raised ICP, because an abscess in this case functions as a mass. So in order for someone to have a CNS infection, they don't necessarily have to have all of these symptoms, but any combination of these should raise some flags, and you should be wary that this person might have a CNS infection of some description. So the first one I want to talk about is acute bacterial meningitis, and this one is the really scary one that people talk about when people talk about the rash that you get. You get that rash and then it's all over the news and such and so on. So that's an infection of the arachnoid mater and the CSF in the subarachnoid space and the cerebral ventricle. So all of that's infected, and there are a number of different microorganisms that can cause infection, and some are more likely than others in particular age groups. So we have less than 1 month, we have E. coli, Listeria monocytogenes, and this group B strep. So that E. coli, it occurs straight after childbirth. The child can aspirate the maternal genital secretion, so that's where the E. coli will come from. In the age group 1 to 3 months, we have our classic 3 that we talk about. So strep pneumoniae, Neisseria meningitis, and Haemophilus influenza. So that's sort of the top 3 causative microorganisms. And again, our group B strep, and then again Listeria. In the 3 month to 5 year kind of bracket, we have Haemophilus influenza, and that's just on its own to show that after the age of 5, it's unlikely to be Haemophilus. It's more likely to be strep pneumoniae or Neisseria meningitis. And then of course in your extremities of age, so upwards of 50, we have again strep pneumoniae and Neisseria meningitis, and then Listeria makes a comeback. So special mentions, Staph aureus you can get in the case of open head trauma or after neurosurgery. It can be introduced to the wound. That's really bad, and that's actually not completely uncommon. And Listeria monocytogenes can occur especially in the cases of immunosuppression or in liver disease. And then when I said extremities, it's just the extremities of age. So then you can see they're less than 1 month and then greater than 50 years from the table. So there are a number of risk factors for meningitis, and you just have to remember that all of those structures in the head and neck are connected. So you can have direct spread, so from the paranasal sinuses, or if you have some sort of trauma, you can have spread there. So it makes sense that the risk factors are like otitis media and influenza A. So otitis media, you can have spread of the infection, or you can just have an immunosuppressed state, which makes you more susceptible to getting bacterial infections on top of that. So that would be in the case of influenza A. Structural pathologies always can expose those brain structures to infection, and then that's the same thing with neurosurgery, head trauma, and asplenia. You'll learn a bit more about asplenia in detail sometime in your course, not now, later. So I'll leave that. Clinical features, so generally a very rapid onset for acute bacterial meningitis. It's all in the name. Fever will be greater than 38 degrees generally, and you might have an altered mental status. The real sort of classic symptom is the meningism that you can get. So that's the combination of neck stiffness, photophobia, and headache. You may not have all three. So all patients with acute bacterial meningitis may not have all three, but I think it's over 80% will have at least two, if that makes sense. So I think most will have two, plus the fever. And then, as I was saying before, so in terms of pathophys, you can have direct spread. The most common is hematogenous spread, though, so that's via the blood. And then again, you can have an introduction of infection from head trauma. The diagnosis for this is pretty interesting. So if you have any of those symptoms like focal neurological deficit, if you have any confusion, if you have any kind of hint of raised ICP, you can't do a lumbar puncture, because as we learned previously, that can lead to herniation. So the issue there is that CSF analysis is kind of the definitive diagnosis for meningitis or encephalitis or whatever. So what you have to do then is, if you suspect any type of raised ICP, the very first thing that you have to do is a head CT. So you do a head CT, and you'll be doing that anyway if the patient has a GCS of 14 or less. So you do your head CT, and you have to rule out any kind of mass cause for any of their symptoms. And then you can go ahead and do a lumbar puncture, and you can do then CSF analysis. So that'll include culturing, and then you can also do PCR if you suspect viral. Now, the issue with that is, what if you don't have a CT? What if you're out somewhere, this patient has acute bacterial meningitis, which is a medical emergency and needs to be treated without delay, and you don't have a head CT, and they are confused, and you think, oh my God, maybe they have a mass somewhere instead and I'm an idiot. So what you have to do there is you take blood and you treat. So the most common spread, as I was saying, was via the blood. So if they've got meningitis, they'll probably have the bacteria or whatever in their blood. So you take their blood and then you just treat immediately. Yeah, and you do need to get some sort of sample, because you don't want to just treat with like random broad spectrum antibiotics. Like, you want to know exactly what strain you're dealing with so you can approach the treatment in the most targeted way. So that was just a little bit of an aside. So yeah, as I was saying, antibiotics. So our most common are penicillin, ceftriaxone, and vancomycin. So if you have an infection that is, like, if you have a patient that's critically ill, you generally give all three. So you'll give penicillin, ceftriaxone, and vancomycin. Sometimes you might remove the vancomycin if you get antibiotics, your antibiotic susceptibility test done, so then you can remove that, but otherwise they generally treat with all three. And that's no different depending on whether it's meningococcal or pneumococcal meningitis. Then you might give them dexamethasone generally for children, and then also for adults with a pneumococcal infection. Hopefully this is all sounding familiar to you, because this was quite a specific, the lecturer that we had was very specific about the treatments that you give, and he gave a very specific lecture, so hopefully this is useful. You might want to then do airway control if they're really quite sick, and then of course infection control, and meningitis is notifiable, so you'll be notifying public health, and they will initiate contact tracing so that we don't have an outbreak of meningitis, which would be quite bad. So viral encephalitis. So I've just copy pasted this little bit that I read off Up to Date, I think it was, but basically to distinguish between encephalitis and meningitis. So meningitis is generally bacterial and encephalitis is generally viral. So with encephalitis, it's because it's an infection of the brain parenchyma, you'll have generally have some sort of altered mental status or a motor deficit or a sensory deficit or something like that in encephalitis, because the brain parenchyma is affected, whereas this is less likely in the case of meningitis. So as you can see here, since viral encephalitis, all of these symptoms that sort of distinguish encephalitis from meningitis are also symptoms of masses. So that kind of just reiterates the point that I was making before about how you need to be careful before doing a lumbar puncture in this kind of patient. So the viral pathogens that usually, there are a number of different viral pathogens that can cause it, but the most common are sort of HSV1, varicella zoster, and then Japanese encephalitis virus. Makes sense. So the point that a lot of resources that I've looked at makes is that HSV1 can be treated with acyclovir. And as is the case with all of the kind of viral infections, is that it's generally self-limiting. So if you get meningitis, that's usually bacterial, but if it's meningoencephalitis, God, what's happening with my words today? Meningoencephalitis, so when it's the combination of the two, that's also generally viral. So it's really just meningitis on its own that you really have to be concerned about acute bacterial meningitis. So brain abscess is kind of the last, well, I think it's the last thing I was going to talk about. But yeah, so you can have brain abscesses at the same time as meningitis. Like, you can have both. And as I was saying before, you can have symptoms of the mass effect. And that's generally the kinds of symptoms that they'll get are going to be like focal neurological deficits and so on and so forth. So you want to do an aspirate in that case to diagnose it. As with every aspirate that you do, there is a risk of spread, but it really is key in order to diagnose what the infection is in this case. So sometimes you can have it secondary to endocarditis. And with the masses, you can have raised ICP and a risk of herniation in these cases. So definitely need to treat. So a couple of the more susceptible patients are patients with HIV or patients who have had a transplant or have leukemia. So those are some of the microorganisms that they are most susceptible to. CSF parameters. So this is how we diagnose. We look at, we take our cerebrospinal fluid and we have a look at it. So it can be a little bit confusing straight up, but there are only like a couple of things that you really need to look at that are really key when you're looking at CSF parameters. So with bacterial infections, you'll have your white cell count will be way up and it'll be acute in the case of bacterial infection, so you'll mostly have neutrophils. And of course your proteins will be up and your glucose will be down, like a lot down. But that's kind of the same for both bacterial and viral, so that's not always the best way to look at it, but definitely leukocyte count will be way up. In viral, again, you'll have elevated white cells, but this time they're mostly going to be macrophages, because viral's a little bit, it's not as acute. And then this one, subarachnoid hemorrhage, is just to show you can do you don't generally do CSF, but you can do a CSF and you'll just get lots and lots of blood. Like, makes sense, right? So here is a little bit of a case that I found. So a mother of a 5-year-old girl realizes that her child has spent all of Saturday in bed. Sounds like me. The girl is listless and not arousable. At the emergency department, the examining nurse practitioner notes a temperature of 38.8 degrees and nuchal rigidity. A lumbar puncture yields slightly cloudy CSF with elevated protein and decreased glucose. A culture of CSF is most likely to yield which of the following organisms? So, yeah, so as I was saying before, temperature's up, nuchal rigidity, girls spending all day in bed, like, these are all huge red flags for meningitis. So that's probably the first thing that you're thinking of. It seems like it's quite an acute presentation. So it's been like less than 24 hours. And when we do our lumbar puncture, we see cloudy CSF with elevated protein and decreased glucose. So that's kind of classic of bacterial meningitis. As I said before, because the protein glucose is kind of variable, I would also definitely, in this particular question, I would also be thinking, oh, what are the white cells doing? But yeah, so you should be thinking kind of acute bacterial meningitis with this kind of presentation. So, as I said before, most commonly strep pneumoniae, so that's kind of what I'd be saying the answer is. That is what the answer is. So, HSV isn't a cause of encephalitis, so the symptoms that she's got are classic of a meningism and not really any of those sort of like altered mental status kind of symptoms, which is what you kind of get in encephalitis, because HSV causes encephalitis primarily, not really meningitis. Giardia lamblia is just like not relevant, and neither is aspergillosis. And neither of those are bacteria or viruses, so yeah. So I think that was almost everything. Oh, the last thing I wanted to mention was, if you have, say your patient wasn't a 5-year-old girl, say the patient was a 1-month-old, they're not going to come into ED and be like, oh, I have nuchal rigidity and photophobia and headache. Like, babies don't talk, right? And then furthermore, if you ask mum and dad, oh, does your baby have photophobia or nuchal rigidity or whatever, they're going to be like, let's leave. So basically, if you have a very small person come in with meningitis, they're going to present with like uncontrollable crying. And what you want to do is you want to check their cap refill, because if their cap refill is delayed, you're really concerned about sepsis, because in the smallest, youngest of our population, they don't have very good immune system, so a local infection can very quickly become a systemic infection. And yeah, I think that's all that I wanted to say about that. I had to pause and restart this a few times because I had a couple of coughing fits. But hopefully this helped, and hopefully I'll see you all next week. Yeah, I'll see you guys next week. Anyway, thanks so much. Bye.